Such progression is almost never an emergency. When in doubt, getting a second opinion might allow one to consider an alternative to what was suggested. Here, the patient can indeed do something themselves. For example, ensuring these medications are taken regularly.
What does regularly mean?
Daily, at a comparable time of day.
Today we're going to talk about a situation that causes many cancer patients a great deal of concern. When, despite receiving therapy, a patient experiences a progressive disease, or what's commonly called progression. Here, however, we're specifically discussing a GIST disease that progresses despite TKI therapy. I want to say so much about this. Fortunately, there are many more treatment options for GIST disease. Today, we have the chance to speak with Professor Reichardt, Chief Physician of Oncology at Helios Clinicum in Berlin-Buch, about this. Professor Reichardt is a long-standing GIST expert, and we are very pleased to be able to discuss this with him.
My pleasure.
My main intention with this video is to offer some hope and encouragement to those who are affected. But if the disease is progressing, even with ongoing treatment, what other options are still available?
As you've already mentioned, fortunately, for this condition, there are many, and over time, an ever-increasing number of new, additional therapeutic options, so that today, we are in the very fortunate position of being able to offer patients a broad spectrum of choices. When the first drug we started using, imatinib, was introduced more than 20 years ago, there were no treatment options available before that. That was a dramatic step, moving from, there's nothing you can do for an advanced illness, to, now we have a medication that works exceptionally well. Unfortunately, it subsequently became evident that even this remarkably effective medication, in numerous instances, does not maintain its efficacy indefinitely. Instead, patients, as you have already mentioned, regrettably still experience a progression of their disease over the course of time, often spanning several years. This then raises the crucial question: is there another medication available that we can utilize? Over the years, additional medications have been developed, and today we have 4 successive lines of therapy available. This means that in many cases, and often in the majority of patients, we can manage the disease effectively for a considerably longer time.
My first question about this is, when the disease progresses again, we call it progression. What does that mean specifically here?
First of all, we have to make sure that what we're seeing is truly progression. And by progression, we mean that the disease is actually continuing to advance. I'm mentioning this because we are familiar with the phenomenon in this particular illness, that during treatment, the findings, the metastases of a potentially still existing primary tumor in the body can change, and in some cases, they might even grow somewhat larger. However, what is sometimes interpreted as a result of the therapy, which should actually be seen as proof of its efficacy, but might be misinterpreted, has now become a little larger. This can really only signify that there is disease progression, especially when this type of therapy was first introduced many years ago. This was often a major stumbling block and frequently led to misdiagnoses. Therefore, the first step when progression is suspected is for the treating physician, as an expert in the disease, to examine it closely. They either reevaluate it themselves or typically discuss it in detail with the radiologist who prepared the report, who hopefully also has experience with this specific situation. So, what exactly do we mean by progress here? Is it truly substantial progress? Or is it perhaps just a minor adjustment, a slight shift? That is absolutely crucial. Another important point is, such progress actually never generates an emergency situation. We often hear statements like, the disease is progressing, we need to act immediately. In those situations, patients sometimes feel like they don't really have the time to think things through, or perhaps seek a second opinion. It can sound as if it's an emergency, as if something has to be changed right away, whether that means switching treatment, having surgery, or starting another procedure immediately. With very few exceptions, it can be stated quite clearly: such progress is practically never an emergency. There is always time to carefully consider all the options, and if in doubt, to get a second opinion. Perhaps an alternative to the proposed solution could also be considered.
We certainly hope that these patients are already receiving treatment at a specialized sarcoma center or from experienced GIST experts. If someone wanted to get a second opinion at this point, where would it make the most sense to turn?
Of course, it also depends on where the patient is being treated. Every patient absolutely has the right to seek a second opinion. That's completely legitimate. But in some extreme cases, what we sometimes see is what I would rather drastically describe as second opinion tourism. What this means is that patients ask a great many different people, hoping that someone will tell them, it's really not that serious, everything will be fine again, and so on. Especially if perhaps the recommended or the explained course of action doesn't correspond to what the patient himself was hoping for. If, however, the patient is receiving treatment at a facility where there are legitimate doubts about the necessary level of experience, then a second opinion should always be obtained.
You had said earlier that progression is not an emergency. But on the other hand, you shouldn't wait indefinitely until you change or start new therapy. What would be a reasonable time frame for you where you would consider that acceptable?
This is a very important point. Of course, sometimes patients hear this and think, well, then I could go on holiday first, or maybe deal with it after the summer. But that's obviously not what we mean. When we say it's not an emergency, we simply mean that there is usually enough time to think things through and make a decision within about a week or 10 days. However, one should not postpone it for an extended period, at least not until one has thoroughly evaluated the precise extent of the progress that is actually involved.
And is it even possible to comprehend why it's advancing so rapidly and what its underlying causes are?
We understand that quite well, in fact, better than with many other diseases and many other therapies. But perhaps a preliminary remark first. We have now formulated progress very generally. The disease progresses. We must distinguish there are actually different ways such a disease can progress. I would like to briefly mention 3 examples. The first one would be that the available evidence simply increases in quantity. This means we know the findings, the primary tumor, if it's still present, and the metastases, we know their location. They were measured at some point, and now they're measured again, and they've grown larger. Another scenario is that new findings have emerged that weren't there before. So, a patient has a tumor in the stomach and perhaps metastases in the liver, and now, additionally, new metastases on the peritoneum, for example. That is, of course, a very different situation than if the existing findings have simply grown a little, but no new ones have appeared. That can, under certain circumstances, significantly influence the decision. How urgent is the situation now? Is it truly necessary to switch? Could we perhaps wait a little longer? The third situation, which we need to discuss separately because it carries different therapeutic implications, is what we call a focal progression. This means that out of many findings, only one is increasing. Let's assume that for this particular patient, 10 or 15 metastases are already known. 14 of them will remain completely unchanged, while one of them begins to significantly grow. This is a very specific situation, which we actually only encounter in a few diseases and under certain therapies, namely exactly the situation as we see it here, with gastrointestinal stromal tumor and its treatment with tyrosine kinase inhibitors. The underlying cause lies in the resistance mechanism, which we will discuss in more detail shortly.
You've just presented 3 quite distinct examples of what we call progress. What would be the best course of action to take in each of these cases?
The very first question that comes to mind is whether any action is truly necessary. This might seem a little bit counterintuitive at first glance. Even though a progression has been clearly identified and the illness is demonstrably worsening, the question still arises. Do we really need to change anything right now? Or can we simply continue with the ongoing treatment as it is? This whole situation is based on 2 main considerations. First of all, scientific studies have shown that continuing a therapy can still be effective, even if the disease shows a slight increase. In other words, a small amount of growth doesn't necessarily mean the treatment has stopped working. As the saying goes, it's far better if something grows very slowly than if it suddenly starts growing quickly. Because, and this is the second point to consider, the follow-up therapy that I choose has no guarantee of its effectiveness. Furthermore, the subsequent therapy may be less tolerable under certain circumstances. a point we will still need to discuss in detail. This means I have two crucial things to consider. Firstly, I cannot promise the patient that the follow-up therapy will be effective, let alone more effective than the current treatment. And I might have to subject him to more side effects under certain circumstances. So the question always arises whether one shouldn't rather continue with a well-tolerated current therapy, which doesn't completely, but largely, keeps the disease under control, before switching to the risk of worse tolerability and potentially even worse efficacy.
Can you change the therapy and then go back? Is it possible or not?
That might be possible in theory, but it's generally not recommended to keep switching from one option to the previous without a clear plan. That should definitely not be done. The general rule is, we have several lines of therapy available, but that number is finite despite everything. So it's not that after every line there's a new one, and after the 10th comes the 11th, and after the 20th, the 21st. It is, despite everything, limited. This means we must handle the available therapy lines with great responsibility. And the crucial motto is to extract the absolute best from each individual therapy line, meaning to fully utilize each one to its maximum potential before we consider switching to the next. It was also scientifically well substantiated that this brings about significantly better long-term results.
And the second example that you brought up, how would you approach that?
We look at whether any new findings have appeared or whether existing ones have grown slightly. In general, we don't change much based on small changes alone. However, if new lesions appear, we usually shorten the follow-up interval a bit, simply because we don't yet know how these new findings will behave. So, if you know the patient has several findings in one area of the body and they're growing just a little bit, then you have a better overall picture because you've perhaps been monitoring them for a year or two. Previously stable, now a bit larger. But if something new suddenly appears, then of course the question is, how does that behave? Is that perhaps something that grows faster? So, I'll have to take a somewhat, let's say, short-term look at whether a situation might develop from this that could then imply a more rapid transition after all. For focal progress, that's a completely different situation. At this point, a localized resistance begins to develop. This means the treatment no longer works at that specific location, while in other areas of the body, the therapy may still be working quite well. In that case, it makes little sense, of course. I had just mentioned 20 findings in that example. It could be 10 or even 15. That's not really the decisive factor now. So that means I would now change the treatment, even though for 19 out of 20 cases, I'm actually quite satisfied with the effect. Only one is progressing. That brings up the question of a completely different therapeutic approach, specifically a local therapy. What this means is that I would specifically target that one particular finding, while continuing the current medication exactly as before. The overall treatment wouldn't be changed, because all the other findings are still under control. Only the one that has clearly progressed would be treated in a different way. In this situation, surgery can be an option, meaning the finding could be removed. Of course, this has to be discussed with the surgeon first. Is it technically feasible? Is that problematic? Will the patient afterwards potentially have problems that we would certainly want to avoid? This must be discussed very carefully. There are also other procedures. These findings can be destroyed by heat, they can be destroyed by cold, they can be destroyed by radiation. These are different methods. It then depends on what specific methods are available at each respective center. Those who have access to all available methods can choose the best one. But if only limited options are available, one should be self-critical enough to say, we could do this, but another method might actually be better. In that case, I would prefer to refer the patient to a center where that method is available, even if we don't offer it ourselves. To be honest, it doesn't always work that way. But this would be a typical situation where a patient might seek a second opinion. For example, if they're told, we want to treat this in a certain way now, and the patient asks, are there other options? And the answer is, yes, there are. But we don't offer them here, so we should just go ahead with this tomorrow. That's a point where you'd say, well, I'd rather hear what other alternatives might be available.
Yes.
So, not all procedures are always suitable, It really depends on what exactly is the finding. Where exactly is it located? Is it in the liver or on the peritoneum? And how large is it? What kind of structures are in the vicinity? Large blood vessels or any other specific configurations? The applicability of the methods already depends on this, so we can say that in this particular case, only one approach works, while in another, perhaps this or that. And then we must consider. It's an interdisciplinary decision. That means the decision is not made by a single individual, but rather it is discussed in an interdisciplinary tumor board, where all the experts for all the different procedures come together. They examine the images, and then they consider what is truly the best option in this specific case. The patient has a right to have what is truly best for them chosen, and this must be guaranteed in precisely that way. This means it is an option only for a localized progression. It is not considered if all findings are now increasing in size. Even then, one occasionally hears the question, can't all of these be surgically removed now? This has been very thoroughly investigated with the clear conclusion. It makes absolutely no sense.
So, it simply causes more damage than it provides benefit.
It definitely does more harm than it provides any benefit. And for that reason, it should absolutely not be done.
You've mentioned the word resistance several times, and I think that brings us to the key question. How does this progression actually happen?
Yes, this is, fortunately, very thoroughly researched. I had already mentioned that we actually understand this much better than in many other situations where a therapy no longer works effectively, and it's difficult to explain clearly. What is the actual underlying reason for it? The reason for this is that the underlying cause, the specific mutation in these tumor cells, represents a significant change in their genetic material. This alteration then leads to changes in how signals are transmitted and processed within the cells.
Yes.
And this disrupted signal transmission is inhibited by the medication, which, in the first line of therapy, is imatinib. This stops the growth signal, and the cells cease to grow and eventually die off over time. Through a further change, an additional mutation, a so-called resistance mutation, which, as the name suggests, causes this tumor cell to become resistant, unresponsive to the medication, a transformation occurs, and the signaling pathway reactivates. What this implies is that the cell awakens once more and then starts to proliferate again. This particular secondary mutation does not necessarily manifest itself in every single cell, but rather only in a select few. Furthermore, there are various distinct types of resistance mutations that subsequently influence the overall effectiveness of any follow-up therapies. If such a resistance mutation, and I'm referring back to our example of 20 samples where 19 remain unchanged and one begins to grow, then this resistance mutation originated within that single sample. These cells have now become resistant and are growing again. The other 19 lesions don't show any additional mutations. That means they're still sensitive to the medication, so the treatment can safely be continued. We need to emphasize once more that these resistance mutations are in addition to the original ones. So the question isn't that it was this mutation before, and now it's that one, but rather it was this one, and the other one is an additional mutation on top of that.
So does that mean I'll have to take 2 medications from now on? One for the old, one for the new?
The really crucial question, then, is how we deal with these new therapies. When these treatments were originally developed, the idea was quite straightforward. If one medication stopped working, we would check whether another medication might still be effective. This is how we've developed various medications over the years. Not all of them have proven as effective as we had hoped. But fortunately, all the ones we now have available, which are also accessible in pharmacies, have proven effective for those patients whose previous treatments had stopped working. And so you can switch from one therapy to the next. The development of some of these medications dates back a very long time, to an era when the details, as we understand them today, were not yet precisely understood. Today, we understand this much better, and therefore, we can also explain the therapies much more effectively. To explain their effectiveness, or indeed the ineffectiveness of these treatments. Current developments are also very much focused on this. How can we further improve therapy in the future, beyond the options we currently have available? But that is a completely separate point. For now, let's stick with the existing therapies. So if progression has clearly been confirmed, meaning the disease really is advancing, and if it's not just a single lesion, but a more general progression, then we may first wait for another follow-up scan to be sure that a change in therapy is truly necessary. And if the next check shows that the disease has increased further, then the conclusion would be, yes, now it's time to change the treatment. In that case, you move on to the next line of therapy. The order of these therapy lines is generally well established, meaning there is a defined sequence that guides which treatment is used next. It is laid down in national and international guidelines. There is no room for maneuver either. That means you cannot choose. For example, going from 1 to 3 is not allowed. First, there's no solid scientific evidence to support this, and it also hasn't received any official approval or authorization. This means medications are approved for the specific condition for which they are available and covered by health insurance. And if you don't adhere to these regulations, you risk the health insurance saying no, that it's outside the scope of approval, and they won't cover it. We must maintain the sequence. But the current scientific research is precisely focused on that very point. The currently accepted sequence will most likely change considerably in the next 1 or 2 years.
Oh, really? So many research findings are on the verge right now. It's also a question of when such resistances develop. I think that's a bit harsh. But is there anything patients do or don't do that can cause this?
The precise mechanisms responsible for the development of this resistance have not yet been fully elucidated. There's a strong possibility that the cells, in their desperation, simply try to find some detours, as it were, to escape the medication's control, and then eventually a secondary mutation arises. And with that, the cells manage to evade the medication's control. It's possible that some cells are already resistant to a particular medication from the very beginning. That isn't entirely clear, but the development of these resistances is the most likely explanation for what we observe. The question then is, what can a patient do in this situation? We really have to say, actually, nothing at all. These resistances simply develop on their own, and unfortunately, we are unable to explain why they progress so very quickly in one patient, but not in another. Let's stick with the first-line medication, imatinib. This works for many patients for many years. We have patients who, since this medication became available, have been taking it for over 20 years, or continue to take it, and eventually passed away at a very old age from something else. So, not from GIST. It was controlled by the medication for years, decades, and then something else occurred, which can happen in old age. That also exists. So, the spectrum of how long the therapy works is enormous. In the worst case, the disease may start to progress again after only 6 to 9 months. That naturally raises the question why, since the treatment usually works much longer. In some cases, however, we still don't fully understand why it stops working so quickly. However, there are a few important things to keep in mind, and in this situation, patients can actually contribute quite a bit themselves. One key point is that these medications must be taken consistently and regularly. So, you don't just take them sometimes, and sometimes not. This, in turn, is due to the mechanism of action of these medications. Simply put, the medications work inside the cell by competing with the cell's fuel. This means either the fuel takes effect or it cannot take effect because the medication blocks it. If I omit the medication, then the fuel can take effect again, and the cell immediately wakes up. And by immediately, We're talking here about orders of magnitude of perhaps 24 hours. This means if you begin such a therapy, you can't, by taking an image, see that the tumor is already smaller. But from other experiments, we know that within 24 hours, the cell's growth is already being blocked. Similarly, if the medication is not administered, the cell will also very quickly reactivate. And we can, I believe, quite reasonably assume that such a constant cycle of waking up and then falling dormant again naturally stimulates the cell to actively search for alternative solutions, and consequently, it's possible that such resistances will develop much more rapidly. This is a little bit speculative, but at least a reason to explain to patients how it works, and to make them aware that the medication should be taken regularly.
Could you elaborate on that? What does regularly mean?
That's the natural question. Do I need to set an alarm? Does it really have to be taken at exactly the same time every day? No, it doesn't have to be that strict. Regular simply means taking the medication every day. Take the main first-line drug, imatinib, for example. It's taken daily in a specific dose. This should also be adhered to, and not just taken, then perhaps skipped for a week because you're going on vacation. Or you say, oh, I'll generally skip it on weekends, or something like that. That should definitely not be the case. It must be taken regularly every day, at roughly the same time.
Okay.
The patients either take it in the morning, or they take it in the evening. And for those who take it in the evening, they simply take it in the evening. Whether that's at 6 p.m. or at 20 past 7, it really doesn't matter. But not just once in the morning, then again in the evening, then skip it again. Then maybe you take the ones from the last 2 or 3 days thinking, oh, I'll catch up now and swallow 3 at once. You should definitely not do any of that. So daily, regularly, at a comparable time of day. The question sometimes comes up, I've forgotten one. Should I take it now? The answer to this particular question is also quite clearly no.
Okay.
If one of them has failed, then that's just the way it is. However, if someone regularly misses 3 doses every week, then we really need to have a serious conversation about why that is. If a dose is forgotten occasionally, that's usually not something we even need to discuss. But if it seems that the importance of taking the medication regularly hasn't fully been understood, then it's important to talk about it again, very carefully. What's the reason for this now? And it's often advisable to involve family members in the conversation, which we generally recommend. That in such discussions, of course, when available, family members are present to then provide mutual support. So, the patient is sitting there, and then I often like to ask the wife, tell me, does your husband take this medication regularly? Yes. And then you can already see under the table, a warning shin kick is threatening, and that's when it comes out. Well, Hans Ulrich, or whatever his name is, last week you weren't quite so diligent in taking it, were you? Because if I ask the patient directly, do you take it regularly? The answer I always get is, of course.
Yes, okay. I believe there are 2 perspectives. So sometimes patients themselves wonder if the medication is sufficiently present in their blood. Or perhaps you as a doctor also ask yourself if the medication is sufficiently present in the patient's blood. Can this be measured?
This has been attempted for many, now more than 2 decades. In principle, it is possible to measure the medication or its metabolic byproducts in the blood. But ultimately, this approach hasn't truly proven effective in the sense that one can draw reliable conclusions from it. We are evaluating the effectiveness of the medication and its tolerability, specifically focusing on these 2 crucial aspects. We assess the efficacy through follow-up examinations to determine if the therapy is working and if it performs exactly as we would expect based on our extensive experience. And we check the tolerability by observing any side effects to see if they are particularly pronounced or if they are just as one would typically expect for such medications. And from experience, it then becomes clear that everything is within the normal range. But there are situations where you get the feeling that it's somehow quite different. In theory, one could consider measuring the drug level in a patient's blood. However, this isn't very informative because it only shows how much of the medication is in the bloodstream. What really matters for its effectiveness is how much of the drug actually reaches the tumor cells. And to what extent that truly correlates That's still a separate question. So, ultimately, blood level measurement doesn't really help us.
But if you have your Hans Ulrich, whom you just spoke about, you can only find out that way that he's not actually taking his medication regularly, right?
There are also indirect ways to see whether a patient is taking the medication. Certain changes usually show up in routine blood tests, such as the blood count or a few other lab values. If those values remain completely normal and unchanged, that can raise doubts. And then it's reasonable to ask the patient again whether the medication is really being taken as prescribed.
And what about the follow-up then, especially in the situation we are discussing now, specifically with progression?
So, follow-up monitoring means we must regularly check whether the tumor responds to our therapy, meaning it at least doesn't grow further, or perhaps only very, very slowly grows, or hopefully shrinks, or conversely, rapidly increases. I need to monitor this on a regular basis. The standard procedures for this are computed tomography or magnetic resonance imaging. While ultrasound can occasionally be an individual option, it is not established as a routine follow-up examination and is also not recommended in the guidelines because I cannot document it properly. A patient can take a CT or MRI scan on a CD or Blu-ray disc with them anywhere. You can look at it. With ultrasound, that's not possible. You're dependent on the facility. A treating physician might describe something one way, but when you review it yourself, it may look quite different, and there's often no reliable way to compare the two. That's why this approach isn't really suitable and isn't recommended in the guidelines. Instead, we rely on imaging, usually a CT scan or MRI of the abdomen, to assess whether the therapy is working as expected. For a patient who has been taking this for a very long time, I don't need to do such frequent checkups because I know it's all working well. You can conduct the checkups with wider intervals. When a patient's condition progresses and I change the medication, I have to schedule the checkups relatively quickly because I don't know if my new medication will work. This means your next checkup won't be in 6 months as usual. But this time, you'll need to come back in 2 or 3 months, depending on the circumstances. We need to monitor things more closely because something has happened, and I can't be sure that my new medication will do what I'm hoping for.
Can these checkups also be done locally, close to home, where a radiologist is available? Or do patients always need to come to the sarcoma center?
Yes, that's a bit of a double-edged situation for 2 main reasons. Firstly, at the very heart of it, you naturally know precisely what you need to pay very close attention to. And then, under certain circumstances, you also make somewhat more comprehensive recordings. And if a person goes to a practice that doesn't have much experience with this particular subject, then, under certain circumstances, perhaps only a somewhat limited imaging program is performed, with which one then, under those same circumstances, might not really be able to gain much detailed insight. From the patient's perspective, the question often comes up. Otherwise, they would have to come in twice, once for the examination, and then again a few days later to discuss the results. It's more involved, but it offers the assurance that all checks were done on site, that you can then look at it yourself again. If the report is a bit unclear, I'll call my radiologist and say, "Tell me, what's the situation there exactly?" Then he says, "Come on over, I'll show you." Then you discuss it again. You simply have a much better handle on it. So, if a patient asks what we recommend, then that is our recommendation. And if they then say, "Oh, that's too complicated for me. Can't I just get the images from my radiologist? An old school friend of mine lives right next door, so I can always get appointments very quickly." That's one way to handle things. But we've also encountered situations where I show the images to my radiologist, and he'll say, "Well, this looks a bit different from how we usually do things here. I can't really make a good comparison right now." Follow-up checks should ideally be carried out using the same procedure, meaning they should be done with the identical method, and all in one place. It's always problematic when you have to go for a CT scan at one location, then an MRI at another, and then an ultrasound somewhere else in between. You can't really get anything truly useful or cohesive from that kind of scattered approach. If you're willing to put in the necessary effort, having everything done by a single provider is certainly the much better option. However, it can also be managed differently, though perhaps with some small compromises.
All right. Thank you very much. We were actually going to discuss the topic of side effects in an upcoming video, but I believe we've really covered the topic of progress quite thoroughly now. So, Professor Reichardt, thank you very much for that, and we'll see you shortly in the next video on side effect management.